This video will discuss the classification of drugs known as depressants. So one type of depressant we're going to talk about are opiates. So opiates are derived from the opium poppy. At least some of the naturally occurring ones are. So there are naturally occurring opiates that come from the opium poppy, and then there are some that are chemically similar. So some of them are synthesized from a combination of the opium poppy and other things, and then some are truly just synthetic drugs. So some that you may be familiar with are morphine, heroin, and methadone. Morphine is synthesized from the opium poppy, and then heroin is synthesized from the morphine and is much more potent than morphine. Morphine, we know that we use it as a pain reliever. It's prescribed, after surgeries and things like that. Heroin, of course, is a class 1 drug. It's thought to have no known medical purposes. Methadone is a synthetic version, or synthetic opiate, I should say, that is used to treat heroin. Some others you might have heard of is oxycodone or hydrocodone. Oxycodone, a slow-release version of it that you might be familiar with is Oxycontin. Now, there's a huge problem in America with oxy addictions, with this drug being thought to be safe as a pain reliever, safer perhaps than some other drugs, and so it's been widely prescribed. But we know that it's very addictive, and then what happens sometimes is people that are addicted to Oxycontin, when they can't get those pills anymore, they can get heroin cheaper and much more readily, so they end up becoming heroin addicts. So these drugs decrease sensitivity to pain and increase relaxation. So they're given medically to decrease pain after a surgery, chronic pain, an injury, whatever it might be. But they're also taken recreationally to increase relaxation. And what they do in the brain is that they attach to endorphin receptors. So we have those naturally occurring endorphins that we've talked about in our body, and there are receptors in the brains for those. And so these opiates can mimic and act as agonists and actually attach and bind to those endorphin receptors in the brain. So that's what this diagram is trying to show you here. Here we have an opiate receptor. Here we have an opiate binding that endogenous endorphin receptor. And we believe that it indirectly increases dopamine release. And so here you have an opiate receptor terminal, you have it adjacent to a dopamine receptor terminal, and so that somehow indirectly this opiate binding to the endorphin receptor indirectly releases dopamine, and thus having that addictive property. Another drug that can be classified as a depressant is marijuana. Now, the main active ingredient in marijuana is THC. It actually goes and binds what are known as cannabinoid receptors on the presynaptic neuron. So we have these naturally occurring cannabinoid receptors in our brain, and when someone smokes marijuana, that THC in the marijuana goes and binds these receptors. These receptors are very widespread. We have them in the cerebral cortex, the cerebellum, the basal ganglia, the hippocampus, and that's why the effects of marijuana can be so diverse and so varied and so extreme. Marijuana also does have some medicinal purposes. It can be used to treat pain, combat glaucoma, increase appetite, and obviously it has become legal in California. And one of the more common uses of marijuana is actually another active component, which is CBD. And so you can actually breed those marijuana plants so that they're either high in THC or high in CBD, and CBD doesn't have that intoxicating effect that you might feel with marijuana. So the question then would be, how is marijuana addicting? If it's acting on these CBD receptors, or cannabinoid receptors in the brain, perhaps we think that it may indirectly release dopamine in the nucleus accumbens. That would be one way it would be addicting. Of course, that's controversial because some people might say that marijuana isn't addicting, and others would argue that it is. It is a drug, so you have to consider that it's still not safe to drive or operate heavy machinery when you are under the influence of marijuana. So some of the effects of marijuana: decrease in pain and nausea. That's a very good medicinal effect of it. Intensification of sensory experiences, the illusion of time slowing down, potential memory and cognitive impairments. And this diagram is just kind of showing you a summary of all of that. And the areas of the brain, it's widespread. There are a variety of different cannabinoid receptors all over the brain. So another drug that we're going to talk about that can be classified as a depressant is alcohol. So alcohol, we know the effects in the brain is that it enhances the response of GABA at the receptors. So GABA is our main inhibitory neurotransmitter, and what alcohol does is it has an actual binding spot, or we think it has a binding spot on that GABA receptor, and it goes and it binds in that spot, and then it modulates or alters the activity of those GABA receptors, allowing GABA to have a longer effect. And it works much in the way that benzodiazepines and barbiturates work. And so that's why a lot of times the effects of alcohol are very similar to the effects you'd see in someone who's on taking a barbiturate or a benzodiazepine. Slurred speech, things have slowed down, their cognitive processing isn't as fast, clumsiness, things like that. Alcohol also appears to block glutamate receptors, which is the main excitatory neurotransmitter in the brain. So overall, the effect of these two things is you're enhancing GABA, inhibiting neurotransmission, you're blocking glutamate, so you're blocking, again, transmission. The combination of the effect would be decreased brain activity. And so that's just what this is showing you here. Here's someone who is sober, and here's someone who's intoxicated. And again, the blues and the greens show very low levels of activity. And then, of course, a third way that it has an effect on the brain is to increase that dopamine activity in the nucleus accumbens, just like the other addictive drugs that we've seen. So alcohol is probably the most commonly abused drug. It's legal, and we use it socially. And so because of that, it has this risk of becoming very commonly abused. We associate it with relaxation, but it can also damage the liver, other organs, and cause lots of other personal and professional problems in people's lives. So is there a genetic influence of alcoholism? And the answer is yes. So type 1 or type A alcoholism, as it would be classified, is later, more gradual onset after the age of 25, seems to have fewer genetic relatives with alcoholism. So again, it's those events that happen in life that cause the drinking to become out of hand, and then the alcoholism sets in. Type 2 or type B is an earlier, more rapid onset before the age of 25. So at a very early age, this seems to have more genetic relatives with alcoholism, and men seem to outnumber women with this type. And so this is just one way of classifying alcoholism. And again, if you see the similarities, though, is that early onset of the disease seems to have more of a genetic component than a later onset. And just to talk about this type 2 or type B a little bit, is my husband's family, his stepbrothers, siblings, I guess. There's 5 of them. And out of the 5, 4 of them are alcoholics. One of them in particular, I don't know the story between all of them, but one of them in particular says, he started drinking heavily at the age of 12. That his parents didn't realize that he was drunk most of the time between the age of 12 and 18 before he left home. And he's had some good moments and bad moments, and right now he's in recovery. But just the fact that he had this early onset, and then he has 3 siblings that also have that are also alcoholics is kind of a testament to this idea, I believe. So there are some drugs that are used to combat alcohol abuse. And again, they're only used in very severe cases when other rehabilitation techniques have not worked, therapy, AA, whatever it may be. And so basically the way that this drug works is by antagonizing the effects of an enzyme called acetaldehyde dehydrogenase. And this is what enzyme is used to break alcohol down. And so when that doesn't occur, there's an accumulation of acetaldehyde in the body, and it results in sickness. And so this is just kind of showing you have alcohol, you have your alcohol dehydrogenase, and acetaldehyde builds up. And then you have this acetaldehyde dehydrogenase that breaks that acetaldehyde into acetate. Well, if this is blocked, you get a buildup of this acetaldehyde. And so it's nausea, but the face gets really flushed and hot, very cramping, I've heard, very unpleasant. And so what happens is you give an individual, and they take this disulfiram on a daily basis, and then if they were to drink, they would have these convulsions, this nausea, it's very severe reactions. And so it's supposed to try to prevent them from drinking at all, but then if they do, condition them to not want to drink anymore. And so I actually have a friend whose sister has taken antabuse. And I asked her about it because I said, can't they just stop taking the drug when they want to go on, one of their binges? And she said, no, because the drug stays in the system for a period of time. And obviously an alcoholic doesn't plan out when they're going to have a relapse. And she said she's actually been with her sister when she's been on the antabuse and chosen to drink. And she said it's scary. The thought that her sister was going to die and the amount of pain that she was in was not pleasant. Yet she's done it multiple times. And that's just how severe her alcoholism is.